leads teaching hospitals, and who's a consultant anaesthetist there. It'd be really good to hear about your stories of how AI can impact healthcare professionals in the action of what they do day to day. Thank you.
Thank you very much. So my name's Alwyn Kotzee. I'm an anaesthetist, and you've had AI academics, people that understand a lot about AI, then had someone who understands a lot about science. I am neither of those. I know a thing or two about patients, and I know a thing or two about trying to get patients through services, which is a whole different kettle of fish sometimes. And in some ways, I hope you'll pardon me, because I am going to be a little bit of a bearer of bad news here. There are many areas in healthcare where AI isn't transforming medicine at all. I was really interested to hear Richard and David talk about traditional neural networks. Not from where I'm standing, mate. It's paper. There genuinely are big areas in healthcare where there is still paper. So there is a transformation to do way before we can get to AI. But of course, those barriers, so I am going to talk about barriers. I'm going to talk about barriers to adoption, but also to adoption at scale, outside of niche areas. Because there are some areas in medicine where, in niches, as clearly is the case with fertility, things are moving ahead very rapidly from other areas. And the reason why I want to focus on these barriers isn't so much because I want to bring you bad news, although I do love puncturing a bubble. It is also because, well, barriers are opportunities. If you can go overcome a barrier, then you've created an opportunity. You've created an opportunity to make a difference for patients. You've created an opportunity for your own business and so forth. So the first thing to say is that neural networks and so on, when you look at it from the clinical end, there is an awful lot of, well, we've got no idea what that is. But there is a lot of artificial intelligence. What is artificial intelligence? Well, or analytics, it is effectively the science of getting answers from the data, rather than giving the data to a human and getting them to make a judgment. Now, as far as that is concerned, it is an extension of traditional medical statistics. Now, there's an awful lot of it about. Just shy of 1 in 100 of every single paper in medicine published about every single field: fertility, anesthesia, orthopedics, public health, infection, COVID, whatever. Just shy of 1 in 100 of every paper published now is supposedly about artificial intelligence. So there is an awful lot of it about. Oh, I've skipped. Oh, there's a slide missing. The missing slide was one of, there are different kind of levels of AI. And we tend to think of AI that has less human involvement as somehow better or more advanced. So your large language models, your neural networks and so on, really have your adversarial things that are becoming prominent in the AI field, really have no human or very little human input into transforming the data before the machine starts learning. And of course, at the other end of the spectrum, you have this wetware neural network that I've passed things through for ages in order to make judgments. But there is something in between where the data has been transformed by humans and then fed into a machine. And at the human end of that, the bottom end of that, is traditional logistic regression. It is a form of getting answers from the data rather than from the humans. And in as much as that is the case, it is a form of artificial intelligence. And those models, those what you might call on one level simple models, but of course on the other level they're more complex because the humans were more involved, those models we've been managing for ages. And they've had massive impacts on medicine. in fields as diverse as stroke risk. If you have atrial fibrillation, the first thing your GP will do before deciding whether to put you on blood thinners or not is apply a logistic regression model to some data that you provide them in order to guide this decision making. In my field of organ transplantation, the allocation of who gets a liver before whom, what the order is, the selection order, the selection criteria before you even get on the list, those are all based on logistic regression and increasingly neural network models. So there is a wide set of fields where artificial intelligence in its broadest sense has already made a big difference, which is partly why there's a lot of it about. But I'll tell you another reason in a moment. Now, when you look at what we would commonly understand as AI, neural networks, higher order, less human involvement and so on, and you look at what's actually deployed in healthcare, you can't see this very well, but this is FDA patents and deployed and licensed devices and systems. It's all images. 3/4 of it is radiology. The 12% you can see there, that's cardiovascular. That's cardiovascular images. It's photos of angiograms and so on. Even my own field of anesthesiology, the 4% that's a sort of dark forest green at the top is about being able to scan people, ultrasound, and tell what's nerve and what's vessel and so on. So it's all images. AI is really quite good at images. And it's also fair to say that as far as image analysis goes, it's made impacts in really diverse settings. So this is an image, it's an ophthalmology model that takes a photo of the back of your eye and can tell whether you're going to go blind from a complication of your diabetes or not. And that same model is making impact in the US. They will be selling fancy devices for many, many thousands of dollars because it's FDA licensed. But at the other end of the spectrum, that same model was able in a trial, not just in a low resource setting, but in a low resource setting within a low resource country, so within rural settings in Rwanda, was able to expedite the diagnosis of this condition, diabetic retinopathy, about 11-fold. So it doesn't necessarily duplicate or replace what doctors are doing, but it can tell you who the doctors need to see in which order and speed up that access. Again, taking out many of the time-consuming, mundane sort of triaging tasks where almost by definition, in a condition that isn't often present, if you triage everybody, you've by definition wasted your time in about 90% of those because, well, there was nothing to find. So it's a strange situation where you need experienced people in order to make really quite simple or straightforward decisions with reliability. And AI may have a utility there. It may not be so good for other things. Again, I don't think you can read this. So this is a large language model device which was billed as being ready for adoption. And that was my first try at evaluating this. 22-day-old child presents unable to play piano. And the model, with high confidence, diagnoses developmental delay. And it's really interesting how it almost gets it right. It just almost. The patient is 22 days old and is unable to play the piano. Great. It's a complex motor skill which is usually not seen in infants of this age. So it sort of almost gets it right, but just not quite. And large language models are really good at sounding plausible. They're not necessarily that good at being right, he says, preparing for missiles from the AI end of the spectrum. But I think it's fair to say that clinicians involved in AI sometimes can be our own worst enemy as well. This is a systematic review a colleague of mine, Paula Deeman from Oxford, did. In oncology, risk prediction models, again, AI in the broadest sense, right from logistic regression to neural networks, 152 models developed because the incentives for academics is developing and publishing models. Only about a third of them were validated. because validation, external validation of models doesn't get you grants, doesn't get you high quality publications, and it's a bit boring, isn't it? You're just doing what somebody else has done before. But it's absolutely essential, because otherwise your model cannot be deployed. It cannot be deployed safely. And about 56% of the manuscripts were found by an a priori upfront definition of what is spin in this context were found to have spun their results or exaggerated their results. So clinicians are not blameless in this. So if we put all this together, I'm just going to give you an example of an attempt at solving a problem as a sort of close. If we put all of this together, if we say that AI may be good at expediting rather than replacing, AI may be good at spotting patterns in data, and that the need really is to deploy at scale. Well, this is one problem that is certainly prevalent at scale. The waiting lists for surgery have grown exponentially. And these people, all of them, are getting worse while they're on the waiting list. They're all getting older, they're all getting deconditioned, they're all getting worse. And we clinically are seeing this. The same operation now is just that little bit more complicated than the same operation was 5 years ago, because the patient's been waiting that much longer. So what can we do to try and increase efficiency in this sort of high volume, high need field? And effectively, what NHS England says clinically is entirely sensible. If you, and they've given definitions of low-risk people and high-risk people. And it is entirely sensible to say that you should manage those differently. If you're low risk, you should be expedited as much as you can in order to prevent deterioration. And if you're high risk, well, we need to try and reduce that risk. And there are a variety of tools by which you should judge whether somebody is low or high risk. And the example I want to give you is the obvious one, which is, are you going to be alive after your operation, or are you going to die in the short term from a complication? And whilst there is, and so the standard measure of quality of hospital care or surgical care for decades has been mortality at 30 days. What is your chance of being alive 1 lunar orbit after your operation? Now, there's a whole load of debate whether that's in fact the right measure, whether patients really care, whether they die at 29 or 31 days, but for better or worse, that's the measure. And the traditional mortality risk prediction models are really quite good. And the gold standard is a model called SORT, which is really very parsimonious, only 6 variables, performs really quite well, is quite usable. But before you can use it, you have to have seen the patient. So you've got to see everybody to assess them, to be able to transform all the variables in order to do this risk prediction. So can we do something else? What data is reliably available to everybody at the point of referral for surgery, or at the point of decision to offer surgery? And actually, one of the issues, which Johnny identified right at the very start, is data availability. The only data fields that are actually available and guaranteed to be available at the point of decision to offer you a hip replacement or a knee replacement, back operation, whatever the surgery might be, is your demographics, where you live, and the medicines you're on. That's it. Everything else is in some way, shape, or form dependent on which system your hospital's running, what is it wired to. It is somewhere, it's in your general practice record and so on, but they're not all connected. And NHS Digital have one connection at the moment, which is only live for medicines and demographics and allergies, incidentally. So what can we do with medicines and demographics alone? Can we reproduce, and this is a sort of standard way of assessing discrimination in models, how likely, how good is it at separating the two groups? And the answer is actually that if you point Airlogic's data scientists at a big data set, 250,000 or so patients from Leeds, and hopefully in the near future another 500,000 or so from Bradford, and hopefully in the slightly longer future, another 750,000 or so from London trusts, then, well, certainly in Leeds, you can separate the two groups as well as what clinicians can afterwards, after they've had access to far more data. Now, again, this isn't ever going to replace someone, but it might just help with risk stratification at the very start, which really is in the fields outside image analysis, I think, where AI is going to have its utility. And I think the opportunity for business, for academia, is very much to look at, well, where are the high volume problems and what is the simplest way in which we can understand or try and supplement some of these decisions. So AI in medicine, at least as seen by a clinician, is very much an extension of traditional medical statistics. Most impact to date is in image analysis. Hype is a real problem, not just hype from industry, but also hype from clinical academics and so forth. There are definitely still unmet needs, and I think responsible, careful AI teams have real opportunities. Thank you very much.